Hello and welcome to the Natus Neurotraining Academy webinar series. Our Neurotraining Academy platform provides you, our members, with direct access to the latest educational content in neurodiagnostics, neurocritical care, and neurosurgery, all in one comprehensive location. So visit us at neuro-training.academy. Today's webinar is entitled Nerve Conduction Studies, Uncommon Nerve Tips, Tricks, and Pearls of Wisdom, and it will focus on and present diagnostic tips and techniques used to test some of the uncommon nerves during a nerve conduction study. I'm Dr. George Grazek, Global Medical Education Manager for Neural Pathways, and I'll be your moderator for today. Before we begin, I would like to share some meeting details. All of your lines are muted to manage background noise during this presentation. We will allow time for questions at the end of the presentation, so please type your questions into the question box on your screen. This meeting is being recorded and will be available for viewing at a later date on our Neurotraining Academy website. Our speaker today is James Lewis. Jim is a distinguished board-certified clinician and educator specializing in nerve conduction studies and EMG. With decades of experience, he continues to promote high standards of clinical education, both nationally and internationally. During his career, he has been the recipient of numerous awards and accolades and past president of the American Association of Electrodiagnostic Technologists. Currently, Jim is a clinical application specialist at Natus Medical. So, without further delay, it is really my pleasure to introduce James Lewis. Jim, please.
Hello. So the first thing I'm going to do is turn off the pictures so that we take up a little less of the transmission so we don't delay too much, and also because I'm the least important thing. Okay, so here we go. Here we go. So again, this is all about uncommon nerves, and I think the first thing we talk about when we talk about, oh, I'm sorry, here's a poll question.
Very, very good, Jim. Thank you very much. So we'll have several of these poll questions throughout this presentation. This first one, we have a very diverse audience today from various geographical locations, and it's really beneficial for Jim and myself to know who our audience is today. So what is your current level of patient care? Are you a physician? Are you a technologist, a director, manager, educator of a lab, or other? So I will launch this poll, so please make your choices. Very good. We're getting, oh wow, we're getting tremendous responses here. Okay, great. I will close the poll and we'll share the results. So, wow, 55% physicians, 34% technologists, and then 8% managers, directors, educators, and 7% others. So great, Jim. Thank you very much. So we'll hide the poll, and we can continue. Thank you very much.
So when we talk about uncommon nerves, oh, I'm sorry. Again, I always start my presentations with a quote. And again, working together, we can do great things. So when we talk about uncommon nerves, this is certainly not something we will all agree on. What is an uncommon nerve? You know, big university labs, they may say some of these things that I talk about are actually fairly common. So we all define them differently. So this is my definition. And to be very honest with you, sometimes I define them about how much I like doing them. So later when we talk about the lateral cutaneous nerve of the thigh, I just don't like doing it. I really just don't like doing it. So I call it an uncommon nerve. Truth be told, I probably could do it more often and get better at it, but I don't like doing it. So that's kind of the underlay here, is what is uncommon. And you may look at these and have very different opinions, okay? So these are my opinions. And what makes them uncommon is, of course, how often we do them. That's a big part of what makes them uncommon. The complexity, you know, how hard are they to get? You know, do I need to do side-to-side comparison because they're very difficult? And how useful are they? You know, and that kind of goes with the other ways to answer the question. So I'm going to start with radial motor, and that's a classic example. So since it's a motor nerve, certainly the needle EMG will be useful. And if I can and if I'm struggling, I'm not getting very good results on my my radial motor, I kind of know in the back of my brain, it's, you know, the doc's going to be in a few minutes, and they're going to be able to see it, or they're going to be able to get that data as that data. They're going to answer the same question in a different way. And so radial motor nerve conductions, I call it uncommon. I think it can be quite difficult. So this is the wrist drop, right? Flexor, extensor weakness. We call it Saturday night palsy, and it's really sort of an anatomical, because of the way we're put together. You know, the radial nerve spirals around the humerus. So if we fall asleep on our arm, or someone else falls asleep on our arm, or, you know, called Saturday night palsy because we, you know, had one too many and we fall asleep with our arm over the curb, you know, that might compress that nerve, just because anatomically how we're put together, it's susceptible. It's riding right along the humerus. So use the extensor indicis muscle, okay? And that's the muscle that extends our index finger. I put the active there, and then the reference over the ulnar styloid, but you can use the extensor digitorum communis as well. So either one of those muscles are fine. I like using the more distal one, but again, we're all different, and either are fine. And then we place a reference in a neutral site. So the radial nerve is kind of all the roots of the brachial plexus, all the trunks, but they all go through the posterior divisions into the posterior cord. The radial nerve is sort of a continuation of the posterior cord. Goes through the axilla, and then it wraps around the humerus. It spirals around the humerus, and that's what makes, if you put pressure in that area of your humerus, and in the old days we called it honeymooner's palsy, because, you know, when you're young and you're in love, you might fall asleep in each other's arms, and your head lies right on that bone, which is compressing the nerve against the bone. And then, of course, through the near the lateral epicondyle, and again, we're going to show this in some pictures in a minute, so words don't always do it justice. And then it splits. The radial nerve splits into the deep branch, which we call the posterior interosseous nerve, and then the sensory branch. In the higher up, the radial nerve supplies the three heads of the triceps, radialis, and the extensor carpi radialis longus. And then after it splits, all the extensors in the forearm are supplied by the radial nerve through the posterior interosseous. The sensory, of course, comes down to the dorsum of the hand, and it supplies just the lateral 3.5 digits. And then, so what are some of the things? Certainly we can dislocate our shoulder joint, fracture our proximal humerus, and then occasionally with excessive pressure, like the crutches and things. But in the spiral groove, this is the more common one, is, you know, your fractures, the external pressure, you know, putting pressure on our upper arm for a long period of time causes the extensor weakness, causes the wrist drop. And then, of course, incomplete means that the lateral head is preserved. So clinical relevance, injuries, muscles, and then, of course, the compressions. The compression at the wrist is rare. We call that serralgia paresthetica. That would be just the sensory component from tight watches or handcuffs or things like that. And then, of course, you get just the sensory loss. And yeah, there it is, serralgia paresthetica. So here we go. Now here's, this is the pictures that you would see from our reference help. And this is all thanks to Sanjeev. But when we talk about the radial nerve, you're going to see all three trunks, the superior trunk, middle trunk, and inferior trunk, all coming through the posterior divisions. And then, of course, through the posterior cord. And then you see the muscles that are muscles that could be affected, and finally where we put our active electrode over the extensor indicis. So we stimulate, again, when I record over the extensor indicis, one of the reasons I do that is I can then get this distal response over the forearm. And I do that as much for sanity check, you know, because if I struggle in the other two sites, at least I know I can get something distally. And then the lateral antecubital region, which is a little bit anterior to that. And again, we've got pictures in just a minute. And then I stimulate, try to get above the spiral groove, which means I'm kind of posterior to the deltoid, higher up in the upper arm. And then, of course, the ground is between stimulating and recording electrodes. Takeoff latency for each stimulation point, so I can measure a conduction velocity, and then the amplitude. And again, this is some of the tips are, so this is the forearm stimulus right here, recording over the extensor indicis muscle. And here is this is the lateral epicondyle. Actually, the lateral epicondyle is down here where the fingers are, so you're a little bit anterior to that. And then higher up, distal to the deltoid here. Okay, so we want to get above, the idea on any compression is to get below and above the compression site. And that's why we're doing the kind of here at the elbow and higher up to get above and below the compression site. And here we go again. Here's the same picture. And there's the biceps tendon brachioradialis. So you kind of see where we're stimulating at. And here's a picture that kind of shows us kind of, you know, behind the deltoid. Here's what the waveforms might look like. Now, a couple things. We see the positive onset. That's one of the things we're going to talk about, the tips and tricks, because I think because every muscle in the extensor side of the forearm is supplied by the radial nerve, it's sometimes it's difficult not to get that volume conduction. It's difficult not to get that little positive onset. Now this, of course, is a perfect recording, but you kind of see the amplitude here. It's a little bit different in that middle one. And again, I think that's what makes this a little bit more complex. One of the other things I see often is odd, almost too fast conduction velocities. I think we have some measurement issues as well, because we can't really measure that spiral groove. We can't measure the length of the nerve when we're measuring on the skin. So I think those are some of the things. So the volume conduction, we can sometimes get odd looking waveforms, you know, and that's why we always have to kind of watch that morphology. Make sure we're getting the same nerve and not getting a lot of crosstalk across the nerves and other muscles. So we have to use higher intensity stimulation. And, you know, because of that, are we getting some stimulus jumping? We have to think about, you know, how high we're turning up the stimulus and how much more we have to turn it up at the elbow than we do to get the above spiral groove. Those are just some of the things that add to the complexity. And then, of course, measuring. Conduction velocities can just be odd. They can be odd. You know, you get between the forearm segment and the elbow segment, you get 55. And then the elbow to the above spiral groove, it's 110. And that just is kind of because it's so hard, I think, to measure the actual length of the nerve when we're measuring out here on the skin, because the way it spirals around, I think it can trick us a little bit. And so those are kind of my tips and tricks. Watch the morphology, try to get them without the positive onset, which again, because number one, volume conduction, I think it's sometimes is near impossible. In fact, I'm bald because of that. I think these are just things that we have to be careful about. Whenever I do radial motor, I will do both sides. And that way I think that kind of the struggles will kind of weigh themselves out a little bit, and it can still be a valuable tool. Okay, so moving on, the ulnar dorsal branch, which we used to call dorsal ulnar cutaneous, or the DUC for short. It is a branch of the ulnar nerve, comes right off the ulnar nerve, just distal to the ulna styloid, maybe 5 to 8 centimeters above the wrist crease. Sensory to the dorsum of the hand over the 4th and 5th digit, really just half of the 4th digit. Pure sensory. And comes from C8 just like the ulnar, because it is a branch of the ulnar. It's a distal branch of the ulnar. It is the same as the ulnar. It kind of curves around as it comes off the ulnar, curves around to supply the dorsum of the hand. The rest of the ulnar supplies, of course, most of the muscles in the hand, and the medial half of the 4th digit on the palmar side, and the little finger on the palmar side. So it curves around to supply the other side. injuries in the wrist, certainly. Different kinds of injuries, lesions, things like that. And so if we want to localize them, so one of the things that we can localize is when we get a ulnar neuropathy at the elbow, since the dorsal ulnar branch is distal to that, you would think it would be involved as well. Whereas if the injury is at the wrist, like in Guyon's canal, the ulnar dorsal branch would be spared. So those are some of the reasons we localize it, so it's preserved in lesions at the wrist. Recording electrodes, and again, these are my thoughts. Yours may be a little bit different, and that's okay. I put the active electrode in that web space between the fourth and fifth digit on the dorsum side of the hand, and the reference 3 or 4 centimeters. Because it's a sensory, 3 to 4 centimeters distal. I use 8, but if I struggle getting 8, I might move it up and down. And I think that's true with all these sensories. So here's the demonstration of the sensation. Any sensory nerve, especially the uncommon ones, I think measurements, we measure, we stimulate, but then sometimes we have to move around because we want the best result. And that's why sometimes I say 8, maybe 10, find the best result, okay? And here's a picture of a dorsal ulnar cutaneous, or I'm sorry, a dorsal cutaneous ulnar dorsal cutaneous. Here's another one. So not hard, but I think it's just got some gotchas. So here again, we see it at a C8T1. It goes through the inferior trunk and the medial cord, comes all the way down through the ulnar nerve and then branches before the muscles of the hand. So why is it complex? Because of where it splits. We can't see it, so we don't know where it splits. And again, that's kind of why that absolute measurement can sometimes trip us up a little bit, because we don't actually know where it splits. We don't want to get too far proximal. I don't want to stimulate the entire or the trunk of the ulnar nerve, because then I get motor artifact and things like that. But at the same time, if I get too distal, do I, where does it wrap? When do I start moving more to the dorsal side of the hand, in the wrist, or the down near the ulnar nerve in the palmar side? So you have to look, you have to stimulate, you have to be able to move around. And that's why I say remeasure, because if I move around to find the best response, sometimes then I measure it again and say, oh no, that's like 9.5. It's not 8, it's not 10, it's somewhere in between. And if we do side-to-side comparison, then I want to match that on the other side. I want to be as particular and compulsive as possible. And then stimulation artifact, if you use a high stimulation intensity or a high duration, you're likely going to bury it in this motor artifact. And that's going to be a problem that we have with a lot of these. So, and again, we're going to answer any questions you come up with as we go along. So, medial cutaneous nerve of the forearm used to be called medial anabrachial cutaneous nerve, or what we used to call MAC. MAC was easy. So it provides sensation to the medial forearm, comes directly off the medial cord. Because of that, it's kind of useful in lower trunk medial cord plexus injuries, because if it's affected, it could be lower trunk. If it's unaffected, maybe it's just ulnar, things like that. It is a purely sensory, comes off C8T1, directly off the medial cord, supplies sensation to the medial forearm. And again, localization of the brachial plexus, it can be very useful to localize where the lesion is, okay? And again, it gets a little bit kind of dicey sometimes, but if it's absent, but the radial motor amplitude is preserved, that can localize it to the medial cord instead of the inferior trunk. Things like that. That's kind of why we look at that carefully. Again, it can be injured distally too, tumors, things like that, okay? I use 10 centimeters. Again, this is not hard and fast. Maybe use 12, maybe use 14. And again, what I do on the medial cutaneous nerve is I kind of find the medial epicondyle, and I kind of move up. I say 3 to 4 centimeters, or 3 centimeters up above the medial epicondyle. I never actually measure, but just a little bit up. And then I take my straight edge and I go down to the ulnar styloid. And then I put my active electrode 10 centimeters on down that straight line. Again, that's not always perfect. I find myself moving it around to find the best response, but that's kind of my starting point. And that's what you see here. My cathode and anode are just a little bit proximal to the medial epicondyle. And then I use the straight edge to find where along that line is where I put my active and reference. And again, the reference is 3 or 4 centimeters on distal. And that's what you see here as well. There's an example. And of course, here's another example. And one of the things you'll notice on this one is this is average. There's 8 stimulations in this average. So one of the other techniques we use on some of the uncommon nerves, the ones we don't do every day, the ones that we're a little less comfortable doing because of frequency, averaging can be your best friend. And here we go, because it is the medial antebrachial, or the medial cutaneous nerve of the forearm. It's coming off the medial cord, the inferior trunk, right out of mostly T1. And there's the sensory distribution of the medial cutaneous nerve of the forearm. And so why is it complex? Like many uncommon nerves, especially sensory, we have to move it around a little bit to find the best response. We're never perfect the first time. Maybe that's Murphy's Law, or maybe that's just me, but moving it around, finding the best response, averagings can be your best friend. And then when I describe this to one of my residents or fellows, I always say, use a soft touch. So often when we're doing nerve conductions, we're kind of pushing hard on the stimulator, trying to get down close to the nerve, and that can kind of backfire here. Don't push, soft touch. And again, short durations, low intensity, because the stronger I stimulate, the more I get this motor artifact that you see here in this picture. So I can actually obscure the waveforms. In fact, I would say that this one is obscured, because look at where the amplitude marker is. So again, often I go back and I look at stuff I did years ago and I think, why did I accept that? I hope I accepted it because it was the best I could get at the time. But don't get too much motor artifact, and certainly if you see a lot of twitching, you know you're getting too much motor artifact. So, poll question number 2.
Okay, thank you, Jim. So now we have a more relevant, centered, or focused question, and it is, what trunk and cord supply the medial cutaneous nerve of the forearm? Is it the superior trunk lateral cord, inferior trunk medial cord, middle trunk posterior cord, lower trunk, or the lateral cord? Think about that for a few seconds. I will launch the poll, and please make your choices. So we'll see what our audience thinks on this content question. Very good. Getting quick responses. Okay, a little more. Okay, great. Thank you very much. I'll close it. And let's see what our audience thinks, Jim. 75% say inferior trunk and the medial cord.
And that is the correct answer.
All right.
So lower trunk, medial cord. Right.
Thank you very much. Okay.
Good. So one of the things that happens, and this is a unique thing with Jim, well, maybe not unique with me, but certainly is one of my issues, is I tend to talk too much. So keeping on time is one of my issues. So as I fall behind, keep telling me to speed up, okay? Lateral cutaneous nerve of the forearm. So similar, but lateral cord, okay? And I put a little dot near the, or just lateral to the biceps tendon, and then I measure down to the radial pulse and that's my straight line. Again, I use 10, maybe use something different, C5, C6. So this is an extension of the musculocutaneous motor nerve. So you'll see that the superior trunk lateral cord, exactly like the musculocutaneous nerve that we're going to talk about here in a minute. There's the sensation for the lateral cord, the lateral cutaneous nerve of the forearm, and injuries to the superior trunk lateral cord. Other injuries in the brachial plexus spares this nerve, and then local injuries, and it's rare, but in like things like IV drug use, you can actually get a local injury to this. So here's the picture, and you can see here where we use that straight line down to the radial pulse. And again, I use 10, maybe use something different, but I use 10 right along that straight line that I kind of create. There's a waveform. And another waveform, again, you'll see this one is averaged. Medial and lateral antebrachial, or medial and lateral cutaneous. So here you can see the musculocutaneous nerve here, which is the lateral cutaneous nerve of the forearm, comes right off the lateral cord, superior trunk, C5, C6. And the same thing here, motor artifact. We got to be careful. Don't overstimulate. Use a soft touch. You use averaging. So again, this is similar to the medial antebrachial. I think they both kind of have the same things. And I can't tell you how many times I've seen this big motor artifact after a lateral antebrachial, and they're stimulating the median nerve at the same time as what's happening. So again, soft touch, don't overstimulate. Suprascapular, I find this one of the very, very most difficult ones to do. So suprascapular, we'll do this in patients with scapular winging. Comes up very high on the upper trunk. Supplies the supraspinatus and the infraspinatus muscles. If you have a 2-channel recording, you can do them both at the same time. If you don't, that's okay. Just do them separately. And again, maybe not always even necessary for that. If you're thinking higher up, doing one is fine. Doing the supraspinatus is fine. But certainly if you're looking for the entrapment at the spine of the scapula, you'd want to do both proximal and distal. Reference electrode near the vertebrae, but you'll see in the picture, it can also work fine up on that shoulder bone. Yeah, I'll show it in a minute. C5, C6, directly off the superior trunk. So it comes up very high off the superior trunk. No cords involved. And I think that's what helps us localize lesions is it in the trunk or is it in the cord, by doing some of these nerves like this. Moves this phenolgleno notch, and that's where it innervates this infraspinatus. So there is a little compression neuropathy right there. And if you ever want to know more about that, I've got an interesting case study on that. Clinically, provides shoulder function. So both the infraspinatus and the supraspinatus are a little bit different. So moves the shoulder straight out or moves the shoulder away, things like that. So here's the picture of where the electrodes are. And you can see here that the reference electrodes are over here on the, what's the tip of that bone right there. I think it's kind of where the clavicle and the shoulder come together. It's called something, but I can't think of it right now. But you can see if in a perfect world, you'd see the spine of the scapula right in between these two. So what makes it difficult? So here's some waveforms. And here we go. So right clear up here off of C5, C6 is the suprascapular nerve. Do you see that one? And supplies the supraspinatus and the infraspinatus, high in the superior trunk. So what makes it difficult, of course, is these muscles, the infraspinatus and the supraspinatus, are under the trapezius. So if we stimulate too high, or we just stimulate, or actually maybe stimulate too low, right in the middle of the brachial plexus, or right in the middle of Erb's point, we're going to stimulate all the nerves, and we're also going to stimulate the spinal accessory nerve. And if we stimulate the spinal accessory nerve, we're going to be activating the trapezius, and that's why this can be quite difficult. So we have to be careful about the stimulation. And one of the tricks, if you have an extra channel, is go ahead and measure to the trapezius. Put an extra channel in there and put an active electrode over the trap a little bit higher up in the kind of up in the shoulder, over the trap. And then you can kind of compare the waveforms. If they look the same, it's the trap you're recording, not the supraspinatus. So those are things that you can try. Look around, be careful anytime you're stimulating an Erb's point. If you stimulate in the wrong place or really high intensity, which is it makes it easier, doesn't it, if we just shock them and get it done, but then we activate too many muscles and we get that volume conduction. So again, I think it can be very, very difficult. And poll question number 3.
Thank you, Jim. So we have another question for a great audience, which is clinically competent, very clinically competent, I must say. The question is, the supraspinatus and the infraspinatus muscles are located below what muscle? Is it the suprascapular, pectoralis major, the rhomboid major, or the trapezius? Think about that for a few seconds. I will launch the poll. Please mark your choices. Very active audience, interactive audience too. Okay, great. I will close the poll. And here are the results for our audience and Jim. Oh, wow, Jim, here we go. Looks like trapezius won out.
And that would be the correct answer.
Great.
And that's what makes it why I call it a difficult nerve to do, an uncommon nerve, is just because you got to be really careful you're not recording the trapezius. Okay. So let's talk about the musculocutaneous motor nerve. Again, any of the nerves where I'm stimulating high up in the axilla or in the Erb's point, I can, it just means all the muscles of the arm are essentially in the active recording area. They're all in the hot spot. So we have to be careful, okay? So innervation to the biceps muscle, superior trunk lateral cord. We talked about this with the lateral cutaneous nerve of the forearm. It is an extension of this nerve, okay? So this is the motor portion. Activates the biceps. I try to get the reference electrode over the biceps tendon, but a neutral place is the key. Problem is, what's a neutral place? C5, C6, superior trunk, anterior division, lateral cord. And here's some of the muscles and some of the things that it does. Okay, and again, sensory component, lateral cutaneous nerve of the forearm. So here's the axilla stimulation, and you can see here that as we stimulate in this area, we're activating a lot of nerves, not just the muscutaneous nerve, musculocutaneous nerve. So here, Sanjeev's got his reference electrode on the medial epicondyle, because again, on the biceps tendon, where I just said, you could be in the active zone. You could be getting a cancellation between the active and the reference. So always think about those as we do them and look at the morphology. Here's a beautiful muscutaneous nerve. And one of the things on these proximal ones is, of course, they're very wide. They're big muscles, so they've got a lot of duration to them. So if you use 2 milliseconds per division on your sweep speed, could it be, especially if it's delayed a little bit, could it be off the screen? So be careful, it's very wide. So here we go, now we're stimulating, and you see we're very high in Erb's point. We're not down in the soft part of Erb's point, we're down up sternocleidomastoid area. And again, we're trying to localize just the muscutaneous nerve and not activate everything in the arm. Another beautiful response. And here we go. So again, C5, C6, superior trunk, lateral cord. Here's the muscocutaneous nerve supplying the biceps. So here in my little picture, this is a perfect picture of volume conduction. So you see I've got a notched waveform. You didn't see that on the good waveforms. This is one of the things we get into. Because again, as we're stimulating, we're getting the entire muscle. If we stimulate up in Erb's point, especially if we're down there in that little soft part of Erb's point, we're stimulating every nerve in the arm. And we're going to get this volume conduction. We've got the nerves are running close together. They're supplying muscles very near where we're recording. Our reference point can sometimes be in the active zone as well. So we can get these odd looking waveforms like this. And it's volume conduction because of the proximity of the nerves where we're stimulating. Again, is the movement when we stimulate, is the biceps moving? Is the forearm coming up like you would expect, the forearm coming up, or is the whole arm twitching out, or are you in the right place? These are all things that we need to be very careful about. Again, whenever I do a nerve like this, I do left and right so that I kind of have a sanity check. Same thing with the axillary nerve. The axillary nerve is also C5, C6, but of course it goes through the superior trunk and then goes down through the posterior division into the posterior cord. So it follows somewhat the same pathway as the radial nerve through the posterior cord, but just the upper trunk or just the superior trunk. So this is a recording electrode over the deltoid. Again, be very careful where we put the reference, because the reference, if it's in a hot spot, we're going to get odd looking morphology, or we'll get a little bit of phase cancellation. Okay, superior trunk, posterior division, posterior cord. The deltoid is the big one, of course, and then of course the sensory continues to the lateral cutaneous nerve of the forearm. Oh, I'm sorry. In this case, this is the lateral cutaneous nerve of the arm, so it's a little bit higher up. This would be sensation over the deltoid region, which we actually don't tend to measure, but the axillary nerve does supply that as well. Okay, very good. And then here's the picture. So you see how we're over the active and the reference. And again, where we put the reference, I would think this would be in the active zone, so maybe I'd have to move that around. But see, we're trying to get the superior trunk. If you look at where that stimulator is, we're not down in that soft spot. The Erb's point is kind of, it's that triangle, that soft spot triangle formed with the clavicle, the trapezius, and sternocleidomastoid, and it's pretty soft in the middle. You see, we're higher up than that. We're trying to get the superior trunk without getting the whole Erb's, activating the entire brachial plexus. So here's a beautiful response of the axillary nerve over the deltoid. Oh, if life were that easy. And here, of course, if I can find my mouse again, I think I lost it. Okay, so here's C5, C6, going through the superior trunk, through the posterior division, coming through the posterior cord, and there's the axillary supplying the deltoid. So how do we make it best stimulate? Think about where you're stimulating an Erb's point. Don't just push it down in that soft spot and turn it all the way up, or we're going to get funny looking waveforms. Morphology is not going to look right. And make sure we're getting the correct movement. So in this case, I want my arm coming out from the side, as if I'm lifting it up to the side. So if if I'm getting a lot of musculocutaneous where the biceps is contracting, I might want to move my stimulator around and try to get just the movement I'm looking for. I think one of the things that I see often is whenever we're doing Erb's point, we turn it up, we don't look around, we just kind of put it in there and just activate everything at once, because it's uncomfortable. And if we can get it over with, I understand, but you shouldn't have to use maximal stimulation when you're stimulating an Erb's point by looking around a little bit, okay? So evaluate the morphology. And thinking about where the brachial plexus is. So, and thinking about where the superior trunk and inferior trunk are, and trying to find those when you're stimulating over the surface. So, phrenic nerve supplies the diaphragm, recording electrodes. You got your active above the xiphoid process, and then lower rib cage 16 centimeters out from that. Again, this is a somewhat difficult nerve. We tend to be called to do this nerve in the worst of situations. Often in the ICU, because they're not weaning from the respirator. So it's kind of sometimes is the worst possible recording when we're doing these. Cervical plexus, so this is higher up, it's primarily C4. So this is not part of the brachial plexus. It actually is part of the cervical plexus. Diaphragm, here's the stimulation. And again, here you're going to see we're real low since it comes off above the brachial plexus. I'm trying to get it down low after it's the nerve itself. I'm trying not to get the Erb's point. So here, with the patient's head turned like this, I'm way down, kind of where the sternocleidomastoid and the clavicle come together. Sometimes I have even moved to the midline to get this, because it can be difficult. And here you see the active electrode over the above the xiphoid process and the reference 16 out. So if I was doing the other side, I'd be using a reference on the other side. Yep, sternocleidomastoid join where the clavicle, both sides. One of the things I found over the years is using a longer duration and less intensity, I think, gives us a better results. Again, this can be difficult, and you can get different amplitudes with inspiration and relaxation of the diaphragm. So as the patient breathes in and out. So sometimes I'll actually do both, and then, you know, inspiration left, inspiration right, expiration or relaxation left and right, so I can kind of compare apples with apples. And then we will talk about spinal accessory nerve. Again, a central nerve. I'm sorry. Yeah, central nerve. It's cranial nerve number 11. Often we use this for spinal, for rep stim. Here we are going to use the trapezius muscle. We talked about it when we talked about the suprascapular nerve, but this time we're going to do it on purpose. And this time we're looking for the shoulder shrug. Okay, I don't want the arm coming out from the body. I want just the shoulder shrug. But again, if the patient has scapular winging, we may do just a simple motor nerve conduction on this. And see here again, we're clear up because this is higher up. We're not down in this soft spot of the Irvis point, but higher up. See, along the sternocleidomastoid there. And there's the active in the reference. And there's a nice picture of a spinal accessory. And since we do this with rep stim, we actually kind of find the motor not so bad because we're kind of used to doing it with rep stim anyway. Here's a very nice spinal accessory over the trapezius. And again, high up. So here we're talking C3, C4, not part of the brachial plexus going into the cranial nerve number 11. Here's the trapezius up here. Okay, so watch for the shoulder shrug. Long duration response. So again, check the sweep speed. Here, I'm getting a whole 50 milliseconds. If I was at 20 milliseconds on the screen, this might be cut off up here somewhere. We might not see the entire waveform. And of course, that's important when we're doing left to right comparison because we really want to see the full waveform. We want to get an idea of that morphology. We want to make sure that we're comparing apples with apples. No positive onset responses. And of course, we can say that about any motor nerve, but again, it's utopia sometimes, especially with things like the radial because of the proximity of all the innervated muscles. All right, so I'm watching very carefully on the time. So I'm flipping over to leg real quick. The lateral cutaneous nerve of the thigh used to be called lateral femoral cutaneous nerve. We see this in neuralgia paresthetica, where the nerve gets entrapped somewhat, the obesities, neuropathy patients, things like that. There's a very painful paresthesias. It's not normal numbness. It's a painful paresthesias. It can be very difficult to record. Again, I've got the 14 centimeters below the anterior superior iliac spine. That 14 is a relative number because, again, consider moving it around to find the best response because it can be difficult. Lumbar plexus, L2, L3. So sensation to the lateral portion of the thigh. And so here, and again, I like this picture. This is a very, very old picture, by the way. But I think sometimes we stimulate kind of over here where the femoral motor is, but we don't. We want to stimulate way over here where the anterior superior iliac spine. We really want to get a lot more lateral than the femoral motor nerve. So a picture and a picture of waveforms. Again, they can be very, very difficult. I often tell people I've only been successful a handful of times over these year or two that I've been doing this, and I just don't like it. I think it's hard. The people who have neuralgia paresthetic are the people that it's the hardest to record on. Okay, so I always do the unaffected side first, so I know what I'm dealing with, but even that's backfired. Averaging is absolutely required. And again, just like the other sensories, just like any uncommon nerve or any nerve we don't do frequently, be prepared to move it around to find the best response. I know that's tough. I know patients don't particularly like you for that, but we're really trying to get the best response. Saphenous sensory. So this is a sensory branch of the femoral nerve. So this is where we're moving away from. So most of the nerves we do in the lower leg are all branches of the sciatic, but this is a femoral, and this we can measure way distally. So it's a distal sensory, and we measure it kind of, this is a lower leg technique, and I think I have both distal and lower here, but I'll let you read about those on the presentation. But I do the distal technique. I always say it's kind of opposite of the superficial peroneal. It's on the medial tibial bone, kind of underneath it a little bit. So L3, L4, lumbar plexus, femoral nerve, sensory branch. So it's the only part of the femoral nerve that passes the knee. So here we're on the kind of the anterior side. So the opposite side of the superficial peroneal. We're kind of recording kind of underneath the tibial bone. I don't like to say that, but we're really up close to it, and we're stimulating higher up. Okay, again, 10, 14. Yeah, we say 14, but move around. If we get a great response at 10, is that better than getting a no response at 14? Here's a beautiful Saphenous. And here we go from the lower, from the lumbar plexus. And if we look way out here to femoral nerve, here we go, femoral nerve, here we go. Saphenous, here's the saphenous right off the femoral nerve, L2, L3, and it looks like we've got some L4 in there too. So higher up, sensory only, and again, neuralgia, paresthetica, difficult to record. But again, that's why it's a uncommon nerve, because we don't have a lot of success. I'm sorry, that's saphenous. I'm sorry, I'm losing my mind here. So here we go, saphenous sensory. Here's the sensory distribution. And again, you can kind of see here when the patient's on their back that it's kind of the opposite of the superficial peroneal over here. So again, how do we do it and make sure we're cool? Is perform the unaffected side first. Averaging is absolutely required. And I kind of say the same thing about all these. If you don't find it, and you kind of think in your brain you should find it because you're doing the unaffected side first, look around. Don't think that I saw some folks teaching where they put all the marks on first before they put the electrodes on, and I never liked that, because I like to be able to move around. If I can get a good waveform at 10 centimeters instead of 14, I think that's worth doing. And again, since they're uncommon nerves, and I'm going to do the other side for comparison, as long as I do it on the other side. So femoral motor runs deep enough below the inguinal ligament, supplies the quadriceps. You can record over the vastus medialis, vastus lateralis, it doesn't matter. Get the reference electrode over a bone or a tendon, so it's in a neutral site. Stimulate above and below the inguinal ligament. Again, this can be difficult because the kinds of folks who have this are often the obese folks, and it's very difficult to find this nerve sometimes. It is a motor, so it's a little bit easier than the sensory. L2, L3, L4, motor fibers pass under the inguinal ligament, and that's the key. That's the common entrapment site. And again, I pulled up the old picture because I like this one. It shows both below and above the inguinal ligament, and you see how it's more midline. It's not over here where we did the lateral cutaneous nerve of the thigh. And here it is on a real person. You never wanted to be a resident or fellow in my lab. I did all sorts of things to them. But watch for leg movements. Does the leg kind of straighten, or is it twist, or is it bending at the knee? I want it to kind of straighten. That means I'm getting the femoral. Look at morphology. Again, morphology is very important. It's a fairly isolated muscle group, so you're not going to get a lot of the funny looking waveforms. You're not going to get a lot of volume conduction if you're stimulating in the right place. Again, check the sweep speed. It's a very big muscle, so it's got a very broad look to it. Don't let it clip off. Don't miss part of the waveform because our sweep speed isn't set right. Medial and lateral plantar nerves. These are branches of the tibial nerve. They supply sensation to the sole of the foot, and they supply the abductor hallucis on the medial side, and the lateral plantar supplies the like the ADQP, the abductor digiti quintipetus, on the lateral side. This is often asked for when people are thinking tarsal tunnel syndrome. The medial plantar is the largest of them, so it's a little easier to get sensation to the medial 3.5 toes, and then of course the lateral gets the 1.5 toes on the lateral side. Tarsal tunnel syndrome, that's when we do it, and we're really looking for kind of the comparison, the medial branch being trapped in tarsal tunnel, since there's quite a large difference when we do the motor conduction side to side. There's quite a difference in the onset latency, with the lateral being quite a bit longer. Well, if the medial branch to the abductor hallucis is less than 1 millisecond before the lateral branch to the ADQP, that would be significant of a medial plantar entrapment. And again, you think of it that way because of the difference in the distance. So there you go. This is how we do it. I kind of measure down. So if I use 14, I measure down 10 and up 4. So down 10, move up 4, and then move over 4. And so here's where I stimulate kind of between the first and second toes. And you can see that my recording electrode is up here, very similar to where I'm going to stimulate the tibial nerve on the motor. So here I move down 10 and kind of up 4. And here's a comparison of the medial and the lateral. So this is the mixed nerve stimulation in the sole of the foot. So we often call this sensory, it's really mixed, but you can see the two peaks, and since our distances are the same, we expect a pretty similar onset latency, or latency in general, peak as well. But you can see here that even here with Sanjeev, he's not stimulating a tremendous amount. I think sometimes we think of, that callus and stuff that we need to stimulate real high. We just have to think, and just have to think about what's the right amount of intensity. Don't overstimulate, things like that. So here we go with the medial and lateral plantar nerves. And here you'll see here's the sensation for the medial, and this pink and yellow is the lateral plantar sensation. And those are 2 branches of the tibial nerve. Calcaneal is the third. So how do we make best? It's difficult. Sometimes it's got to thick. This patient lays asphalt for a living, and they've got a lot of callus on their feet. It's a little tough, and it's a little bit tough sometimes because of local trauma. We walk on the bottom of the feet, maybe we jog or run on a treadmill. So the bottom of our feet have some local trauma as well, and that's why we compare side to side and unaffected side first. So, so what I have left here is both the facial and the blink. So just bear with me. I want to leave about 5 minutes for questions. So I'm going to hit these really pretty fast in 2 minutes or less. We're going to make this PowerPoint available to you, so you can certainly read it. And if you have any questions, you can ask anytime. I love this stuff. So facial nerve, 7th cranial nerve. There's several branches that come out, and pictures are the best. Let's get to the pictures. Pictures tell us everything. So here's my active electrode, and I use the opposite side of the nasalis muscle. So if I'm stimulating on the left side, my reference is on the right side. And that way I just flip them around in my amplifier when I move to the other side. I'm looking for more than a 50% amplitude difference side to side. If it's less than 10% side to side, then I get concerned that I've lost enough axons that it may not recover. It's probably a neurotomesis injury. Okay, so here's a perfect waveform. Here are the branches. So this is the central nerve, comes off 7th cranial nerve through the pons, and here are the branches. So I can actually record at any one of these, or if I had multiple channels, I could record all of them simultaneously. But again, think about, go to where the money is. Where's the weakness? Don't overstimulate. And one of the things we do sometimes is if we stimulate with too much intensity, we can actually activate the master muscle supplied by the trigeminal nerve. So kind of when we're doing this, just put your hand over the jaw. Is it twitching as well? Let's not volume conduct to the master. It's a small one. Blink reflex, 2-channel response. So here I'm going to measure both from the 5th and the 7th cranial nerves. And again, pictures are the best. This is an older picture. This one uses the orbicularis oculi, and that part is correct. But where the reference is, years ago we used to place our reference on the nose. Now we tend to place it more laterally out here to the side, and I am going to show that picture as well. But the active electrode is literally just below the eye. In fact, I think one of the things is to be careful not to get those lower eyelashes under the tape or under the electrode, so we don't pull those out. Blink reflex is a 2-channel study. We're going to stimulate right up here in the supraorbital notch and record both sides simultaneously. Now, I think there's a screen capture that everybody can capture this picture and make this your wallpaper, right? Love him to death, or I wouldn't pick on him. Okay, so here's some waveforms. A beautiful R1. So we get a response 1, an R1 on the side of stimulation. We get a second response. This is the response that crosses over through the pons on both sides. So we've got an R2 response both on the side of stimulation. The top one is left, the bottom one is right, and also on the opposite side, but no R1. So again, don't overstimulate. This is very uncomfortable, so don't overstimulate. Habituation can occur, so get them as quick as you can. Okay. Sometimes what I do is I rectify my waveform so I can find the best onset, because these are beautiful onsets. But sometimes at R2, it's not perfect. You get a little bit of muscle in there or something like that. So sometimes rectifying can help you find that onset. So here's a little quote from Lou Gehrig, one of my heroes, of course, who had ALS, and this was part of what he called the luckiest man alive speech that he did at Yankee Stadium back in, I think, was it 1947? So one of my heroes. So I wanted to open it up for questions. So I'm sorry those last couple were pretty fast, but I wanted to give a chance for questions.
Great. Thank you, Jim, for that great presentation. We do have some questions for our audience. Let's take the first one here is, how would you locate Erb's point?
So I'm turning on my camera here, so hopefully you'll see me. So when I think of Erb's point, if you kind of shrug your shoulder a little bit and you feel up there right behind your clavicle.
We don't see your camera.
I'm sorry, I clicked the wrong thing. Yeah, I clicked the wrong thing. I'm sorry. Now you get me there, don't you?
Okay, yes.
Okay. So so right up here, I've got my clavicle here. If I turn my head and kind of push against it, here's my sternocleidomastoid. And you kind of feel where it kind of goes right into the medial portion of the clavicle. So that's 2 triangles. Third one, if you shrug your shoulders a little bit, you feel the trapezius. So if you feel your trapezius down to where it kind of joins the clavicle and turn your head so you can kind of feel where the sternocleidomastoid gathers the clavicle here on the medial side, and that little triangle in between is what we call Erb's point. And so we get the superior portion and the inferior portion and the medial portion and the kind of out here for the lateral portion. But you can kind of feel it if you shrug, turn your head the opposite way. Yep, you can kind of feel the sternocleidomastoid over there. That's Erb's point. It takes a little bit of experience to find the right place. If I'm doing axilla, I'm moving up. If I'm doing if I'm recording over the ulnar, I might move down a little bit. I might move around a little bit. And the idea of moving around is so I don't stimulate the entire arm. I don't want the whole arm frailing around. I want just the part I want to activate, and it's hard, and that's very hard. And the other thing is, don't just turn the stimulus up to 100 milliamps. I see it all the time, but I think it really it clouds your responses too much. So it is something that we have to be careful about. But with practice, you'll get really good at it.
Okay, great. Thank you, Jim. We have another question. For sensory nerves, do you prefer ortho or antidromic stimulation?
It depends on how old you are. So many years ago, we all did orthodromic. So that was important really just on the hand. So I think of median to the 2nd digit and ulnar to the 5th digit, where we would stimulate the digit and record up here on the wrist. And now antidromic is much more popular today. And I think when you think of latencies, they're equivalent, but you do get a little bit better amplitude with the antidromic. So we're recording over the digits and stimulating in the wrist. So we get a little bit better amplitude. And of course, you know, we're struggling sometimes because everybody's abnormal and, you know, everything's taking twice as long because we're looking so hard to find the best results. I think today antidromic is most popular, but I learned orthodromic. Now on the foot, my surals, I do antidromic, but there are people who do orthodromic. I never have. Always use antidromic in the feet. I do.
Okay, thank you. How about another one? Do you prefer or advise recurrent or single stimulations for the difficult and/or routine nerve conduction study?
That is a preference as well. So I don't mind using recurrent or repetitive. I don't mind doing it, but I want it pretty slow. I don't want it going boom, 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 boom when I'm doing a routine nerve conduction. The reason, of course, is when I find that perfect response, I want to have time to get my finger up there and stop the stimulation. I don't want to get a second one and then have to roll back to the previous one. I want to be able to stop it quickly. So I use a interval of 0.5, so I get one stimulus every 2 seconds if I'm using recurrent. Now, I think most of us just use non-recurrent or single stimulus, and that way, you know, stimulate, turn up, stimulate, turn it up, stimulate. We get our best response. We could just stop instead. But again, it depends on a lot of things. You know, for instance, if you're doing a bedside and you're on the opposite side of the bed of the machine, just, you know, there's no room in there. You know, it's a small room. It's an inpatient room, and you're kind of stuck in a bad place. Sometimes recurrent can help you then, but just simply because, you know, you're working in an awkward position. But by and far today, I use single. But in the old days, I used a slow, repetitive stimulation, knowing that I could stop fast enough. But again, it's preference. I don't think one is better than the other. I just think they're different.
Thank you, Jim. Well, this will conclude our webinar for today. I would like to thank James Lewis for his excellent and informative presentation, and to you, our audience, for your participation. Please contact us via email should you have any questions regarding today's webinar. Our email is neuro-training.academy@natus.com. For access to future events and all of our other educational programs at Natus, I invite you to join our Neuro Training Academy. The registration is free, so please visit our website or sign up at neuro-training.academy. Don't forget to review and download the handouts for this webinar, which include, well, the PDF was too large apparently for this, so if you would send me a individual email request, I will forward you the PDF of today's lecture. So on behalf of Natus, our Neuro Training Academy, thank you for joining us today, and we look forward to seeing you next time. Have a great day.